Hello, my name is Jose Granados, and I am very proud to say that I'm currently part of the cardiovascular ICU nursing staff at Banner UMC. I'm particularly interested in the staffing levels of our ICUs and how they affect our patients and their care. So, thus, I'm here to garner your support to establish a staffing nurse model across ICUs in Arizona that determines nursing levels according to frequent assessments of patient acuities. The basic issue of improper staffing ratios is one of decreased nurse availability and increased workload and stressors. So the problem is not just in having proper monitoring and management of each patient, but also in one in which side effects are not seen until later, such as the case with decreased nurse work satisfaction levels and staff retention rates, as well as increased nurse burnouts. A study in 2014 showed that decreasing the nurse workload by just one patient decreases mortality rates by up to 7%. Another such study showed that it decreases mortality rates by up to 9%. Better nurse levels decreases patient readmission rates. This marker is often used to assess quality of patient outcomes, um, and they can be reduced by up to 25% by increasing these ratios. In reviewing and eventually supporting this choice for a policy, I used various different evaluation standards. Two major criteria in favor of this proposed policy are ethics and social impacts. The ethical dilemma confronting ICU nurses when forced to having to care for two equally critical and unstable patients is immense. Being forced to determine which patient to focus on when both patients need attention can have serious health outcomes to one of these patients. So you can see how this could become a moral burden for a healthcare worker. Eliminating this impactful ethical aspect of ICU nursing care by implementing acuity derived nursing ratios is essential to provide mental relief for our current nursing staff. A social marker that this proposal addresses is the development of trust between patient and nurse. A key component of formation of this trust is a patient's knowledge or perception that the nurse will be there for them in an emergent or dynamic situation. Forced to being An absent nurse due to being forced to focus on another patient detracts from this. Each patient deserves timely and proper monitoring during each shift. This plan provides for that level of care within the ICU. If the proposed policy would become a legal mandate, it would decrease nurse burnout, work dissatisfaction, readmission rates, and mortality rates among patients in the ICUs. It would also increase patient and nurse satisfaction levels, monitoring um, levels in the ICUs, and staff retention rates. All these would equal two very positive points. A is that more vigilant, experienced staff availability would provide for higher levels of patient care. And B, it would increase that gold standard of patient care assessment marker, better patient outcomes. The important economical impact of this plan is its cost effective features. Studies show that adding a nurse to each shift costs approximately $590,000 while saving an estimated $1.5 million. The specific plan would cost ICUs in Arizona about $160,000 a year. If we only took readmission rates as a savings comparison, it would provide a savings between $210 million and $600 million each year. In con- with your support, this policy would provide for increased nursing levels when the need arises. It would mean a safer environment for our patients in the ICUs. It would provide for better levels of nurses, better levels of patient care, and better levels of patient outcomes. I ask you this: if your spouse, child, parent, or any loved one was a patient in an ICU, Would you want a plan in place that would maintain enough nurses around to be able to adequately and safely provide for their care? If your answer is yes, then please support this policy. Thank you.